Okay, so I'm going to start. I'm assuming that everybody can hear me okay. And I'm sorry for the technical difficulties. It's surprising because I've been on Zoom literally from 7 in the morning until about 7 at night for the past several days, but I'll get to that at the end. So I want to thank you all for joining us in the virtual town hall, COVID-19 in our community. I want to thank the Lupus Foundation of America, Georgia chapter with Terry and all the staff there. I also want to thank the Georgia Council for Lupus Education and Awareness with Chris Reed and Representative Schofield and others. And also the Georgians Organized Against Lupus Research Cohort and the Division of Rheumatology at Emory. And as always, this is meant to be general information, not to be specific medical guidance, and you should always be double checking with your own medical provider and source documents for the accuracy of everything that I say. But it's my best effort, and the effort that I do, part of it is just to tell you what's going on. I'll give you a summary around the world. There have been over 49 million confirmed cases and 1.2 million deaths worldwide. And since our last town hall, there have been over 7 million cases. So that's the largest ever 2-week increase. And you can see that India is quickly catching up in terms of total infections to the US, but you still see this large gap between the US and India in terms of total deaths. And so that we really need to think about not just the number, but the consequence. And obviously deaths are just part of the picture, but it gives you an idea that there's something qualitatively different about each country in terms of the burden and the impact. And that's what we need to keep in mind. So you can see the heat map across the world, and it certainly does seem like the northern hemisphere is more impacted than the southern hemisphere, doesn't it? Even South America, that used to be bright or dark red for most of the continent, seems to be calming down a bit. The US continues generally to remain very active, more so than Mexico, which has cooled down a bit and has always been worse off than Canada. And then you can see all of Europe just totally bright red. And that's really the big news, or continues to be the news, about how Europe has continued to be a place that really has lit back up. And you remember they were hit very hard, and they successfully dampened down the new cases to the point where things were opening up quite rapidly. And now this has happened. And just to give you a perspective, because again, I'll get to this in a minute, Georgia has been relatively okay, and it's still something to watch, but we don't have a sense of this impact, right? This past 2 weeks, the most number of cases has occurred since the beginning of this pandemic. And just to give you a sense of what's going on in Europe, at one point they were blocking visitors from the US, and here they are in the midst of their own crisis. And it's gotten to the point where it's pretty bad. In Belgium, they have restrictions for the past week where all non-essential shops and businesses are closed. They have no alcohol sales after 8 p.m. You can only do takeout. No bars, cafes, and restaurants are open for any in-person visits. Facilities, cultural, leisure facilities, including gyms and pools, are all closed. Germany, for the past week, only takeout from restaurants. Everything else is essentially closed. Their social contact is by law limited to 2 households with a maximum of 10 people. So obviously large events are canceled, no crowds at sporting events. Churches and schools are open, but obviously there's a lot of variation as to how they remain open. Shops and hairdressers are open, but they have really strict hygiene rules. So if this gives you sort of flashbacks of where we were in the beginning, I mean, this is what we need to watch out for. France, national lockdown since the beginning of the month, and this will be in place until at least December 1st. So that's for sure. They can only leave home to go to work, buy essential goods, or seek medical help or exercise 1 hour a day. And this is again by law. Bars, restaurants are closed, schools and churches are open but very restricted. Social gatherings of any kind are banned. Spain, for the past 2 weeks, they have a stay-at-home order after 11 p.m. It's a curfew, basically, until 6 in the morning, and private gatherings are limited to only 6 people. Now, what you see here over on the right is Asia, and you can see that it's relatively less affected in terms of new cases per day than the West, Europe and North America. And there are lessons that we can learn from here. Not that they can completely apply to us, but these are principles that we should keep in mind to help understand what we should try to aim for or to do the best of our ability. And in Asia, there's more extensive testing, tracing, isolating of cases. Obviously, their systems, the homogeneity of the populations there, the forms of government in some cases make it a lot easier to do these things. And they have a culture that's more unified in the sense that they will approach things that are mandated a lot easier. They have more extensive use of face coverings. They've had to use that for pollution in the past in some areas of China and other parts of Asia. So they're used to these types of measures. There's a more robust public health infrastructure, and populations are better conditioned to cooperate with strict rules and surveillance measures. And while accepting or basically being imposed to trade this off with some impact in terms of their personal rights. And again, a lot of these things are very difficult, if not impossible, in the U.S. But these are measures that impact how respiratory viruses go from one person to another. And it's made a difference, as you can see, in terms of Asia versus Europe. But, in general, I think one of the words of caution that we should take from this is that we need to recognize that removing COVID-19 restrictions should be done very cautiously, and that you can't return to the new normal quickly. It's not an on and off switch, and we have to do it relatively slowly while balancing a lot of other factors. And this is what we're going to have to deal with for a bit. In the US, there's over 9.4 million confirmed cases and nearly, actually over 250,000 deaths in the US. There's been an increase in over 1 million cases since the last town hall that we had 2 weeks ago, over 600,000 in this past week. On election day, there were 1,280 COVID-related deaths. On Friday, there were over 117,000 new cases in the US, and that's the largest one-day total for any country ever. So I know the focus, and rightly so, has been on the election, but what many of us have been distracted about is we've overlooked that we've had the highest number of cases of any country ever in the history of this pandemic. And so it tells you that we're really in a very concerning stage. And when all the public health officials talk about that, even though it may not feel like it, we can't lose, we can't take our eye off the ball. Documented cases on college campuses have passed 250,000, 250,000. So again, the lessons we should learn, we need a clear, coordinated, and phased plan for moving to different levels of controls. We should not ease restrictions until there is a robust system in place to monitor the infectious situation. We need continued measures to reduce transmission so that once things cool down, they can easily flare up again. So we need to keep things under control. And these are concepts that those of us who live with lupus or know somebody with lupus, these are very clear concepts to us, keeping things in remission, right? And we need an investment in public health capacity. So these are the reported cases, and just to underscore, really, we're in uncharted waters in a sense. And I don't mean to be alarmist, but if you look from the beginning of the pandemic, you've heard me say that we never really had an end of an initial spike. There was a spike and sort of a flattening, and then we talk about the second sort of spike, and it really went down, but never to the point where even back to the initial spike. And now, I mean, look where we are in terms of new cases from the very beginning. Now, because of the change of the demographics of who gets it, we don't have, and we know a lot more about the virus and how to treat it. We don't have the high number of deaths as before, but we have a very significant number of deaths, and these certainly have not come down, and you can see it plateaued and definitely starting to pick back up, which is what you would expect as new cases arise. For those that think that a lot of this or most of this increase in number of cases is driven by the temperature, people are forced to come inside more. That definitely is part of the case, but one thing to point against that so much is if you look at and you isolate northern states, you see a difference in these states here. And if you look at the y-axis over here, this is not a linear increase. This is what we call an exponential increase. So it goes from 10 to 20 cases rolling average per day, and then it goes quickly to 50 to 100 to 200 to 500 to 1,000. So it's an exponential increase. And so these states here have really high numbers of daily cases. And these are northern states, but the rate or the degree of the high numbers of cases in these states don't match some of the other northern states. And one major difference between the states at the bottom here that have relatively lower increases during the cold temperatures as opposed to these states up here is really that they represent different regions with starkly different and large groups that have different views of the virus and different behaviors related to the virus. So, the reason why the Midwest and the Northern Plains is really flaring in large part is that the attitude of a large percentage of the population there is that of not doing the protective measures that we've been talking about and having events like the Sturgis bike rally that was a super spreader event. So yes, the temperature is a big issue, but the temperature really won't make a difference if you do the appropriate action. And that's what we continue to preach. In Georgia, this is definitely more of a red map. It's not super red all over like it was before. So we still have a lot of fires, maybe not as hot. And you can see the areas that are involved. The Metro Atlanta area is smoldering, but not as great as some of the areas up in the Northwest, Northeast, central part, and some of the rural areas down south. So you can see in Georgia, the number of new cases, the rate of increase here you can see. So we're clearly on an uptick in terms of new cases in Georgia, but relative to the the similar curve for the nation, it's not as high. So, I think that's the silver lining out of all of this, at least in our part of the world. It's going up. We need to be cautious about that. But I am very thankful that it's not as rapid of an increase that we're seeing in other parts of the country. The daily deaths you can see are generally coming down, but there's a clear sense in my mind anyway that it's going to plateau, and then maybe you're starting to see the beginning of an increase in the number of deaths. Again, you would totally expect that to lag behind the number of cases. We're doing a fair amount of testing, and that remains fairly stable, which is good. We need to maintain that capacity and have the reserve to increase the number of testing as we go into the winter. The hospitalizations have come down, but have plateaued and is starting to go up a bit. It's not in the danger zone. So all in all, we're not in the highest risk level, but we continue to be in the orange. Going back to the hospitalization rate, we worry about ICUs being overwhelmed, and we have decent capacity in the state, but still more than half of the ICUs are being used. And so we need to be mindful of that. The daily cases are definitely on the rise. The infection rate, you want that to be at 1 or under, but and that is a signal that we're going to have more and more cases. And the test positivity rate ideally is below 5, but at least it's acceptable under 10. So that tells us that, again, I think this is the right color for us. We're not in the relaxation zones, and we're just a step from the worst zone, but we're not in the worst zone. And so there's a lot to be grateful and cautious about. So going into the questions, I'm trying to decide whether or not to spend Thanksgiving with my family, and there'll be at least 14 people there, and I'm worried about how careful they have been around other people during COVID. And so it's a risk calculation. I can't tell you yes or no, but CDC has confirmed with other studies, and you can guess this as well, that a lot of the new cases at this stage are being driven by transmission in the home, hosting other families and friends. And that's going to happen more and more as the winter season and the holiday season comes. So this is a high risk event, and you're with a fair number of people, and you're concerned about how careful they've been. So, it depends on the measures that you'll have at that event, whether people get tested before. Do you trust all of them to get tested? Do you impose masking, which would be, I know it's going to be a challenge when you have an intimate event like Thanksgiving. And eating is a time where you can't mask, and so you're going to have to figure out some way to do some social distancing indoors at a family event like that. So all these are a lot of challenges, and it will be the general reason why people fear that there will be increased spreading during the holidays. So I don't mean to dissuade you specifically, but other than to point out that, and I think you're suspecting this as well, that there are a variety of things that are being pointed out in your statements here that point to high risk. I spent time with someone about 6 days ago who just tested positive for COVID. Should I get tested? Well, I would recommend it. And you need to quarantine yourself too, because I'm assuming that you don't have symptoms. Otherwise, if you did, then it would be pretty clear given your exposure and the high suspicion of it. But if you know that you interacted with someone closely for more than 10, 15 minutes, or you had a cumulative exposure to a lot of people over a short period of time that were high risk or known to have COVID, then even if you don't have symptoms, you could be asymptomatic. And that's the big question. Are you infected but not having symptoms? And the danger there is not only will you eventually become symptomatic, but there's a period of time where you're going to be spreading this potentially to other people. If you're not careful, or because you don't have any symptoms, you're not exercising as high level of of safety. So really, the first thing is you need to remove yourself from infecting other people, and you need to quarantine. And so minimize interaction, be very careful, assume that you're positive, and then get that testing done. And remember, this was last week, there's two different categories of testing. One, whether to see if you're currently infected, and the other is whether you've been infected in the past. So we're more worried about this one. Are you currently infected? And there's two tests. The one that is the nasal swab, where they really go back into your nose, and I know nobody wants to do that. That really is the best test for you. If you're asymptomatic, you want to go get a PCR or viral RNA nasal swab test for a current infection. There are antigen tests that are not as accurate. Some of the false negatives can be as high as 50%, but they're quick and easy to do. This would not be an appropriate one for you to take if you know that you've been exposed to somebody. So definitely get a molecular test or a PCR or viral RNA nasal swab. And this is a blood test to see whether you've been infected in the past. And this is something that is not applicable to that particular question. So this is a good place to start, dphgeorgia.gov/COVID testing. You'll see where you can go to get tested. I just heard a recommendation that cloth masks are not enough to protect from COVID. Should we be wearing different masks? Masks are protective. Now, there's different degrees of protection, and the N95, which you may hear of, this is what it's one of the highest levels of protection, and you can't really get them very readily because it's short supply. And so we protect that for people, usually in the medical field, where you're directly interacting with people that are probably infected or known to be infected. But for people who are going to the grocery store and doing daily chores, and even if you're working but able to maintain social distance, cloth masks are good. Again, there's different degrees of that. We've had town halls in the past where we've had videos and slides about different types of masks. You may want to go back and try to find that or search for articles on it. But the scarves, or people that just sort of bring up those bandana type of things and just from their necks and they cover up their nose, that's like the worst, because it's not really designed to cover your nose and your mouth. It doesn't form a nice seal. And then a single layered mask versus multiple layers, and then it isn't going to be as good as multiple layers. How it's designed in terms of sealing the area around it, all factor into it. But when you walk around, you see a whole host of different types of masks. And I think for most things where you are able to try to maintain some distance, going to the grocery store, going to the pharmacy, going even to your doctor's office, I think any type of cloth mask is good. And so it's not a matter of yes or no, cloth mask or no cloth masks. I think you need a mask, and cloth masks are the ones that are most available. And I think they're more than appropriate for people in their general day-to-day activities. If you want to go higher level, there are these KN95 masks that I've discussed in the past where you can order them online. But frankly, I don't think you really need them unless you're in a higher risk position. For those that are in the frontline workers, so including people in service industries, where your job is around people that are not protecting themselves, you're around a lot of people in general, teachers included, you may want to consider a KN95 mask. Can I get COVID from takeout food? What precautions should I take? And it's pretty clear that COVID doesn't get transmitted through food. They have found COVID viral particles on food, but and even in other things, but this again is a respiratory virus. So the virus itself needs to go get into the respiratory tissue, like your nose, in from your eyes down into your back of your nose and your throat, or you breathe it in. So when you eat food, I mean, I guess there's a theoretical risk that some of that can get into your lungs, but for the most part, when you eat, it gets cooked, and it's not a great environment for viruses to be on for a long time sometimes, depending on the type of food and all that. But you eat it and you swallow it, so it doesn't go into the respiratory tract as easily. Doesn't mean that you shouldn't be careful. You should still think about the packaging around it and how people touch it. So I think just general precautions of washing your hands before and after touching the packaging. But the food itself, I don't think you need to do anything too crazy. I remember seeing some YouTube videos early on in the pandemic where people were describing how to disinfect the bags and the packaging to a great degree. I don't think you need to go to that length. Um, just assume that the packaging is infected, but just like anything outside, if you touch it, you just need to make sure you wash your hands. After you throw it away, wash your hands. Before you touch your food, especially your face, wash your hands. So again, washing, washing, washing. Can people with lupus take remdesivir if they get COVID? Yes, there's no particular reason that I'm aware of. I was contracted with COVID from the hospital and the symptoms seem to last. I've been suffering for several weeks with COVID symptoms, these headaches and body aches, no sense of taste or smell, extreme fatigue, insomnia. What can I do? And other doctors are just not really sure and saying it's going to take some time and you need help. And this was also mentioned in previous town halls, but in people without lupus, there clearly is a subset of people that have long-lasting symptoms beyond the infectious period of the COVID. And there's a little analogy to lupus. I think many of you have had that initial episode of lupus, and some very severe, where the inflammation and the immune system is overactive. And then you go through a period of time where your doctors are telling you your labs are okay, they're not seeing any signs of immune activation, but you have this chronic fatigue, this chronic pain. It may be something similar, but in terms of the cause, but certainly many of us can relate to this. And it's horrible that you have a double whammy in the sense of having lupus and sort of these chronic effects from the COVID. We're learning more and more about this. I don't have any specific guidance for you, nor do I have any general guidance at this point, because I think we are at the point where we're still learning more. I mean, at this stage, we have a lot of people that are being acutely infected with COVID, and we are just now starting to see those that are living with the repercussions of having had COVID weeks and months ago. So we're recognizing this more, and there are people that are trying to understand it and looking at immune pathways, looking at what's happening to the body to cause these symptoms. But not enough time has passed, not enough experience has been gained, not enough understanding is there yet to really understand all of the issues that are leading to these chronic symptoms. But hang in there, and I would encourage you to talk to your rheumatologist, because I think your primary care doctors are not going to be the best situated to pick apart these immune and non-immune mediated issues. So there may be some merit to time and just waiting it out, but you don't want to overlook some things that potentially could be addressed and reversed, like acute inflammation and immune activity. So that's one thing you don't want to miss, and your rheumatologist is best situated for that. Over the weekend, I reviewed information from the ACR conference, and that stands for American College of Rheumatology. It's the organization for healthcare providers in rheumatology. It's not a patient-specific organization. It's more for the providers, but they do a lot of work, obviously, because it goes hand in hand in terms of patient-specific issues, but it's predominantly for the providers. Do you have any information from the conference you can share with others, new therapy medications on the rise and recent clinical trials presentations that were helpful? And I told you I've been on Zoom for about 12 hours a day for the past several days, and that's because we're in the middle of this meeting. It's a 4-day meeting. It's going to end tomorrow. There's another day of some post-conference activities, and it's chock full of stuff. And this is just a portion of my agenda from today. These are just part of one session where people have abstracts that were accepted. Abstracts are short research vignettes, if you will, that have been reviewed by committee. They don't go through the high level of review like some of these journal or manuscript articles that I referenced, like the New England Journal, and especially something as prestigious as the New England Journal has a really high level of oversight, and you really need a lot of review and to be the best of the best there. Now these abstracts are not just things that people throw together and say, here, this is what I think. They have undergone some review, and it's a great place to see what people are working on, often there's sort of initial observations, get ideas, see where the field is going. And this is a great environment for clinicians, researchers, and patients, I'll get this in a second, to interact with each other and to share knowledge and all of that. And you can see just among this one session, again, this is only a portion of the abstracts. You see Dr. Drenkert from our group looking at the skin-related quality of life and its association and relationship with psychosocial stress and race in cutaneous lupus. So I know this really speaks to some of you. By the way, these are lupus-related abstracts that I pulled out ahead of time, which is why there's green check marks. And this is under my agenda. And there's a whole host of things across rheumatology, including RA, vasculitis, and all of that. But the lupus abstracts themselves are numerous, as you can see here. And again, this is just one day of 4 days, one morning of that 4 days. And this is just one part of this session. And there's other parts where there are more sort of formal talks, 20-minute talks, usually about 3 or 4 individuals in the field on a certain theme, and then Q&A afterwards. This was virtual this year for obvious reasons. There is a cost to attend. There is a patient registration, and I want you all to help us remember, and this is something that I've talked to Terry about, and it's an idea that I've had, I just haven't had the time to kind of put it into fruition, but I want you to keep us accountable about it. I think this would be a great opportunity for some of you all to attend. We need patient input. And it would be great, I think, to have some people with lupus attend from our area, see what sessions and reports appealed to you all as patients, work with me and other people in the medical advisory board, and then for a while after this annual conference, we can have a discussion of what was presented and talk about it from both a clinician, researcher, and patient perspective, and how it may or may not relate to our community here. So I know Terry is on board. We're going to have some time to think about it, and we hope to implement this in time for next year as well. And no matter where we are with the pandemic, in the years in the future, there is a commitment by the American College of Rheumatology, and I'm on the board of directors starting this year. There is a long-term commitment to have at least a virtual component. I think the best combination is to have both, an in-person and a virtual component, because they each add. in different ways, and it'll be a great way to combine the two. So I think for the years in the future, there will always be an opportunity, at least virtually, to be able to be exposed to some of this information. And depending on opportunities, maybe some of you to attend. So at this point, I'm going to just pause for a second and see if anybody has any questions in the chat that they want to present. And it's okay if you don't. But as I wait, please continue to check the website. Terry does a great job in terms of keeping the information updated and the COVID resources there. And remember that every 2 weeks we'll be here, and to send any questions by 3 p.m. the night of. So with that, hope you guys remain safe, and thank you for this opportunity to share. And I'll have more for you next time for sure. Be well.